Welcome to EP Edge Journal Watch, issue number 5, and welcome to 2026. I'm Dr. Sharma, and this is EP Edge Journal Watch, where we break down the most important electrophysiology research and translate evidence into real-world practice. This year is going to be defining for EP. Pulsed field ablation is moving beyond feasibility into durability and long-term outcomes. Device therapy is being reshaped by competing risk and patient selection. And atrial fibrillation ablation is increasingly shifting from one-size-fits-all to substrate and patient-specific approaches. We start with device therapy because nothing forces clinical precision like long-term mortality data. The extended follow-up of Danish is exactly that, a hard look at what ICDs do and what they do not do in non-ischemic cardiomyopathy. This was the original randomized Danish cohort, 1,116 patients with non-ischemic cardiomyopathy, left ventricular ejection fraction 35% or less, NYHA class 2 to 3, with class 4 allowed if CRT was planned, and elevated NT-proBNP. Patients were randomized 1-to-1 to ICD plus optimal medical therapy versus optimal medical therapy alone. A key feature, cardiac resynchronization therapy, was used in about 58% in both arms, CRTD in the ICD group versus CRTP in the control group, so this is highly relevant to real contemporary practice. Follow-up was captured through Danish national registries with no loss to follow-up, and the median follow-up was 13.2 years. Here's the headline in numbers. All-cause mortality was essentially identical, 52.9% in the ICD arm versus 53.4% in the control arm, with a hazard ratio of 0.96 and a 95% confidence interval from 0.82 to 1.13. But sudden cardiovascular death was meaningfully reduced, hazard ratio 0.54, confidence interval 0.36 to 0.80. This is the central EP concept Danish keeps teaching us. An ICD is outstanding at preventing arrhythmic death, but it cannot override competing risks, progressive heart failure, comorbidity, and non-cardiovascular mortality, especially as age increases, and that age signal is not subtle. In pre-specified interaction testing, patients 70 or younger had a hazard ratio of 0.38, while those over 70 had a hazard ratio of 1.27 with a p-value for interaction of 0.01. So Danish long-term follow-up doesn't say ICDs don't work, it says the mechanism works, but survival benefit depends on who you implant and when. Now, with that lens of precision, let's shift from defibrillators to pacing, where leadless systems are rapidly moving from novelty to scalable reality. Let's move into leadless pacing because the AVR data are starting to look less like a pilot experience and more like an ecosystem. First, the AVR DR eye-to-eye dual-chamber leadless pacemaker study. This was a prospective, multi-center, non-randomized investigational experience with 452 patients across 126 implanting physicians. Primary endpoints were implant success and 30-day safety. The procedural signal was strong. Implant success was 99%, 30-day complications were 11.1%, and importantly, the paper emphasized a learning curve effect. Procedure time and complications declined meaningfully with operator experience. That matters for adoption. When a technology crosses from feasibility to scalability, outcomes become increasingly driven not by the device, but by workflow, training, and patient selection. Now let's take a more nuanced physiologic question. What do you do when you see a high acute atrial capture threshold in an atrial leadless implant? Sohail and colleagues looked at 53 atrial AVR implants in a retrospective cohort, stratified by acute pacing threshold greater than or equal to 3 volts versus less than 3 volts. They tracked thresholds at tether mode after release at 24 hours and at 30 days or longer using repeated measures analyses. Here's the clinical punchline. High acute thresholds consistently declined over time. Mean chronic threshold settled around 0.7 volts. And the predictor that mattered wasn't the acute voltage. What mattered was current of injury. Adequate current of injury predicted favorable remodeling and chronic performance. This is classic EP thinking applied to new tech. Acute numbers are not always biology. Sometimes they're contact, edema, microtrauma, or an early tissue response. So the practical takeaway is restraint. If your implant is stable and your current of injury is reassuring, don't chase a perfect acute threshold at the expense of unnecessary repositioning. From here, we pivot to the other side of device therapy, procedural infection risk, because the next trial is a reminder that small changes can deliver outsized outcomes. Let's talk about repeat CIED procedures and infection prevention, because this is where incremental technique can translate into real morbidity avoidance. Aiden and colleagues published a prospective randomized single-blinded trial in 418 patients undergoing repeat cardiac implantable electronic device procedures. The primary endpoint was bacterial contamination, culture positivity. The secondary endpoint was 1-year device infection. The intervention, iodine-impregnated adhesive drapes. The results, pocket contamination was reduced by about 50%. And at 1 year, the infection rate in the intervention group was 0%. For EP labs doing high volumes of generator changes and revisions, that's a remarkably actionable finding because it's simple, scalable, and aligned with how infections actually happen, contamination at the time of re-entry. Now let's shift to rhythm monitoring, not as diagnosis, but as management strategy. The Artesia AF progression analysis evaluated 4,012 patients with device-detected subclinical atrial fibrillation, followed for a median of 4.1 years. They used time-dependent Cox modeling and adjusted for factors like CHA2DS2-VASc, age, and heart failure status. The progression rate was 9.3% per year, and progression was not benign. It was associated with increased all-cause mortality, increased heart failure death, and increased stroke risk in patients on aspirin. So progression isn't just more AF, it's a biologic marker of worsening substrate and rising event risk, which means progression is not merely an observation, it's a trigger to reassess rhythm strategy, anticoagulation strategy, and overall risk trajectory. That idea is reinforced by the Monitor AF study, 2,293 patients in a retrospective multi-center comparison of implantable cardiac monitors versus conventional monitoring. ICM monitoring wasn't just better detection, it changed management, more rhythm control attempts using antiarrhythmics and ablation. At 12 months, AF freedom was 86% with ICM guided care versus 61.8% with conventional monitoring. Stroke was lower, 0.3% versus 1.6%. Major bleeding was lower, 1.6% versus 2.9%. In other words, continuous data enables earlier intervention and smarter therapy decisions. Now, let's bring that same insistence on measurable outcomes to the most disruptive technology in ablation today, pulsed field ablation, and specifically the VOLT program. Now we get to pulsed field ablation, where the field is moving from it works to how durable, how efficient, and how safe. The VOLT CE Mark program gives us one of the cleanest early chronic effectiveness signals for a first-generation balloon-in-basket pulsed field platform. This was a prospective multi-center pre-market CE Mark investigation across 11 European and Australian sites. 150 patients were enrolled and 146 were treated. Paroxysmal AF made up 70.5%, 103 patients, and persistent AF was 29.5%, 43 patients. The lesion set was pulmonary vein isolation only, with a mandatory 20-minute waiting period and a 90-day blanking period. Monitoring was relatively stringent: ECG, bi-weekly trans-telephonic monitoring, and a 24-hour Holter at 6 months. The primary safety endpoint was serious device or procedure-related adverse events within 7 days. The effectiveness endpoint combined acute PVI success and freedom from AF, atrial flutter, or atrial tachycardia longer than 30 seconds after blanking through 6 months. Let's talk acute performance first because it was elite. Acute PVI success was 99.1% of pulmonary veins, 573 of 578 veins. On a per-patient level, acute success was 98.6%, 144 of 146 patients. First-pass isolation was 97.6% of veins and 94.5% of patients. Average pulse field applications were 17.6 per patient, plus or minus 5.7. Total procedure time averaged 100.4 minutes. Left atrial dwell time was 39.4 minutes. Fluoroscopy time was 17.3 minutes. Now safety. The primary safety event rate was 2.7%, 4 of 146. 2 were major vascular access or bleeding events, 1 tamponade, and 1 pneumonia. There were no deaths, no atrioesophageal fistula, no phrenic nerve injury, and no clinically significant hemolysis. At 6 months, freedom from documented AF, flutter, or atrial tachycardia was 88.2% in paroxysmal AF and 76.7% in persistent AF. The primary composite effectiveness success was 86.2% in paroxysmal AF and 72.1% in persistent AF. Freedom from symptomatic recurrence was 90.2% in paroxysmal AF and 74.4% in persistent AF. And there's an important subgroup signal. Among patients off class 1 or 3 antiarrhythmics after blanking, arrhythmia-free rates were 89.7% for paroxysmal AF and 84.4% for persistent AF. Durability is inferred from the redo subset. 7 patients, 4.8%, underwent repeat procedures. In that redo group, durably isolated veins were 82.6% overall and 93.3% post-blanking. This is why the Volt CE mark dataset matters. High acute success, low early serious adverse events, strong 6-month effectiveness with stringent monitoring, and encouraging redo durability. The 12-month CE mark outcomes presented at FHRS 2025 add longer horizon context, still within a single-arm PVI-only framework. The cohort remains 146 total patients, 103 paroxysmal, 43 persistent. At 12 months, freedom from documented AF, flutter, or atrial tachycardia was 83.5% in paroxysmal AF and 58.1% in persistent AF. Quality of life improved meaningfully. The AF EQT score increased by an average of 24 points from baseline, with a p-value less than 0.0001. Reintervention signals were also strong. Free from repeat procedure at 12 months was 94.5%, 138 of 146. And among those who returned for repeat procedures, durable isolation was seen in 90% of veins, 27 of 30 veins. Though it's important to remember this reflects a redo-selected sample, not mandated remapping. Now let's connect those chronic CE mark signals to the acute credibility established by the global IDE dataset. Lowe and colleagues reported the Volt AF IDE trial as a prospective, single-arm global IDE study across 38 international centers enrolling between April and September of 2024. 392 were enrolled, including 57 roll-in cases. The primary analysis cohort was 335, and 320 patients ultimately underwent PVI with the Volt system and formed the primary analysis population. AF type was nearly balanced, 51.9% paroxysmal and 48.1% persistent. Mean age was 65 plus or minus 11 years. 64.7% were male. Mean CHA2DS2-VASc was 2.3. Mean ejection fraction was about 59%. So a relatively healthy LV population. The protocol was strict. PVI only, no adjunctive left atrial lesions, mandatory 20-minute waiting period, and confirmation of entrance block after waiting. Acute effectiveness was near universal. Per vein acute isolation was 99.4% in paroxysmal AF, 666 of 670 veins, and 99.8% in persistent AF, 633 of 634 veins. Per patient acute success was 98.2%, 162 of 165 in paroxysmal AF, and 99.4%, 154 of 155 in persistent AF. First pass isolation was 92.1% in paroxysmal and 89.7% in persistent AF. Energy delivery was efficient, 18.5 applications per patient, plus or minus 3.6, often fewer than other contemporary PFA systems. Workflow metrics: total procedure time was 105.9 minutes, ablation time 34.7 minutes, left atrial dwell time 44.1 minutes, and fluoroscopy 14.4 minutes on average. Zero fluoro cases occurred in 4.1%. 13 patients. General anesthesia was used in 82.4%. Safety: the primary serious adverse event rate within 7 days was 1.9%. Events included 2 tamponade or perforation events, 1 pericarditis, 1 ischemic stroke in a patient with CHA2DS2-VASc of 5 where an anticoagulant dose was held, 1 vascular access complication, and 1 prolonged hospitalization. No deaths, no atrioesophageal fistula, no phrenic nerve injury, and no pulmonary vein stenosis were reported. Lab markers suggested myocardial injury rather than hemolysis, with stability in hemoglobin, haptoglobin, bilirubin, and creatinine. So what does Volt give us right now? IDE establishes acute credibility and workflow. CE Mark provides early and intermediate chronic signals. What we still need is rigorous comparative durability, but the data already place Volt firmly among the leading PFA platforms. Next, let's move beyond technology and talk personalization, because some of the most important new AF data aren't about energy source, they're about strategy. Before we close the discussion on pulsed field ablation, there is one study that must be addressed because it answers a question no randomized trial can. What happens when pulsed field ablation leaves the trial environment and is deployed at scale? That question is answered by Manifest US. This was a retrospective, investigator-initiated, multi-center safety registry evaluating real-world pulsed field ablation use in the United States. After FDA approval of the Pentaspline PFA catheter, invitations were sent to 435 U.S. centers. 102 participated, contributing data on 41,968 consecutive patients treated between February 2024 and July 2025. This is now the largest safety data set for pulsed field ablation ever reported. The patient population was unselected and real-world. Median age was 68 years, 56% were male, 73% were first-time ablations. AF type included 54% paroxysmal, 37% persistent, and nearly 6% long-standing persistent atrial fibrillation. Pulmonary vein isolation was performed in over 92% of cases, but importantly, more than half also underwent posterior wall ablation, and nearly 1/3 had cave o tricuspid isthmus ablation, meaning this was not a PVI-only population. Now the safety signal. The overall major complication rate was 0.63%. Pericardial tamponade occurred in 0.16%, stroke in 0.1%, vascular complications requiring intervention in 0.18%. 30-day mortality was rare, 0.04%. Critically, there were 0 cases of atrioesophageal fistula, 0 cases of pulmonary vein stenosis, and 0 cases of persistent phrenic nerve paralysis. These are the complications that have historically defined the ceiling of thermal ablation risk. Manifest US also did what smaller data sets cannot. It surfaced rare events. Coronary artery spasm occurred in 0.1%, most commonly during CTI or mitral isthmus ablation. Hemolysis-related acute renal failure requiring dialysis occurred in 0.02%, and there was a very low but non-zero signal for unexplained sudden death or cardiac arrest, approximately 0.019%, occurring days after the procedure. This is exactly what real-world registries are meant to do, not to declare perfection, but to define the true safety envelope and identify where vigilance is required. The take-home message from Manifest US is not that pulsed field ablation is risk-free. It is that when deployed across more than 40,000 patients, its safety profile remains consistent with myocardial selectivity and fundamentally different from thermal energy. When you place Manifest US next to controlled IDE and CE mark trials like VOLT, the picture becomes clearer. PFA is not just efficacious in trials, it appears scalable in practice. And that combination, efficacy plus real-world safety, is what ultimately changes standards of care. While large registries like Manifest US are essential for defining real-world safety at scale, they also serve another purpose. They remind us that even exceptionally safe technologies can have rare complications that only emerge with widespread adoption. That brings us to an important and timely report from Gunawardene and colleagues published in early 2026 in Circulation. This is not a trial and it is not a registry. It is a multinational case series designed to highlight rare but life-threatening delayed ischemic and arrhythmic events occurring after pulsed field ablation for atrial fibrillation. The investigators collected cases from 7 high-volume international centers between March 2023 and July 2025. Among 6,721 consecutive PFA procedures, 11 patients experienced severe delayed adverse events. That translates to an incidence of approximately 0.16%, or roughly 1 in 600 procedures. The patient profile is worth noting. The mean age was 65 years, nearly 3/4 had persistent atrial fibrillation, and almost half had known coronary artery disease. Importantly, 9 of the 11 patients underwent ablation beyond pulmonary vein isolation, most commonly involving the left atrial posterior wall, CTI, or other non-pulmonary vein targets. The clinical presentations were heterogeneous but alarming. 5 patients developed delayed ST segment elevation with a median onset of about 20 minutes after the final PFA delivery, though the range extended from minutes to more than 20 days. Several of these patients progressed to ventricular fibrillation. 2 patients experienced malignant ventricular arrhythmias, including ventricular fibrillation occurring during or shortly after the procedure. 2 others developed profound bradyarrhythmias, including high-grade atrioventricular block and prolonged junctional rhythms. And tragically, 2 patients suffered sudden cardiac death, occurring 3 days and 22 days after ablation. Autopsy findings available in 2 cases were particularly revealing. 1 patient demonstrated spontaneous ventricular fibrillation without evidence of myocardial infarction, tamponade, pulmonary embolism, or obstructive coronary disease. Another showed an acute inferior myocardial infarction in the absence of plaque rupture, thrombosis, or embolism, raising strong suspicion for delayed coronary vasospasm. Taken together, these observations suggest several plausible but not yet proven mechanisms. These include delayed or generalized coronary vasospasm, electroporation-related release of vasoactive mediators, ionic shifts affecting repolarization, autonomic imbalance with vagal or sympathetic perturbation, and interactions with underlying coronary or microvascular disease. Importantly, some events occurred despite prophylactic atropine or nitroglycerin administration, underscoring both the unpredictability of these rare events and the limitations of current preventive strategies. The authors are very clear about the limitations of this work. This is a small retrospective case series. It is hypothesis generating. A causal relationship cannot be definitively established, and similar delayed catastrophic events have been reported, albeit rarely after thermal ablation as well. Still, the clinical message is important. Pulsed field ablation remains an exceptionally safe technology at scale, as reinforced by Manifest US and other large data sets, but it is not risk-free. The EP Edge interpretation is this: rare does not mean irrelevant. These events appear more likely when ablation extends beyond pulmonary vein isolation, particularly in patients with persistent AF and underlying coronary disease. In an era of same-day discharge, delayed ischemic or malignant arrhythmic events demand heightened vigilance. For practicing electrophysiologists, this means maintaining a low threshold for telemetry, electrocardiography, and coronary evaluation when unexplained symptoms or ECG changes occur after PFA. It also reinforces the need for continued post-market surveillance and transparent reporting as PFA adoption accelerates. When viewed together, Manifest US tells us what usually happens. This case series reminds us what can happen, very rarely, but with devastating consequences. Responsible adoption requires understanding both. To close this issue, let's step back from individual devices and energy sources and focus on where atrial fibrillation ablation is clearly heading: personalization. One of the most compelling examples comes from the PAF by left atrial wall thickness trial, which asked whether lesion delivery should be tailored to left atrial wall thickness rather than using uniform ablation index targets. This was a prospective, multi-center, randomized, non-inferiority trial enrolling 156 patients with persistent atrial fibrillation undergoing first-time ablation. Patients were randomized 1-to-1 to a left atrial wall thickness guided strategy versus a conventional closed protocol. In the left atrial wall thickness guided arm, three-dimensional CT-derived wall thickness maps were displayed to the operator and ablation index targets were adjusted accordingly. In the control arm, operators used standard posterior and anterior ablation index targets without wall thickness information. At 12 months, arrhythmia-free survival was similar between groups, meeting non-inferiority, but efficiency differed substantially. Total procedure time was reduced from 80 minutes to 60.5 minutes, and radiofrequency time was nearly halved, from 28.6 to 14.4 minutes, without an increase in complications. This trial reinforces a core electrophysiology principle. When energy delivery is matched to atrial substrate, efficiency improves without sacrificing efficacy. Personalization was also explored through a different lens in the tailored F trial, particularly in the pre-specified subgroup analysis of women. The parent study randomized 370 patients to either pulmonary vein isolation alone or a tailored strategy combining PVI with AI, assisted spatio-temporal dispersion guided ablation. Women comprised 77 patients, or about 21% of the cohort, and had higher CHA2DS2-VASc scores and more persistent AF at baseline. In women, the tailored strategy produced a striking benefit. Single procedure freedom from atrial fibrillation at 12 months was 76% with tailored ablation, compared with 50% with PVI alone, corresponding to a hazard ratio of 0.31. While freedom from any atrial arrhythmia showed a favorable trend without reaching statistical significance, the signal suggests that PVI-only strategies may underperform in certain substrates, and that selective escalation may be more effective than empirical lesion sets for all patients. Another pragmatic personalization strategy comes from observational data examining patient height as a surrogate for atrial size and lesion requirement. In 206 patients undergoing paroxysmal AF ablation, first-pass pulmonary vein isolation occurred in 68% of patients shorter than 172 centimeters, but only 47% of taller patients. When ablation index targets were increased in taller patients, specifically raising anterior targets from 450 to 550, first-pass isolation improved to 66%, and acute pulmonary vein reconnection fell from 22% to 2%. Together, these studies highlight a central theme in modern EP. Personalization does not always require new technology. Often it requires smarter application of what we already have. When these personalization strategies are viewed alongside the pulsed field ablation data discussed earlier, particularly the VOLT trials and the 40,000 patient Manifest US registry, a broader narrative emerges. Atrial fibrillation ablation is moving away from uniform protocols and towards strategies informed by substrate anatomy, continuous rhythm monitoring, and real-world safety at scale. As we move deeper into 2026, the most important question will no longer be which catheter is newest or fastest. The question will be which approach delivers durable rhythm control with the lowest cumulative risk for each individual patient. For those who would like to explore all references, detailed tables, figures, and visual infographics supporting the studies discussed today, they are available in the EP Edge Journal Watch newsletter on LinkedIn. If you have comments, questions, or suggestions for future issues, I genuinely welcome your input. You can reach me directly at epedgecast@gmail.com. Before we close, I want to say a personal thank you. I'm Dr. Sharma, the author of EP Edge Journal Watch, and I'm deeply grateful to each of you who continue to read, listen, and engage with this series. Your thoughtful feedback, your discussions in the lab and clinic, and your commitment to evidence-based electrophysiology are what make this work meaningful. Please consider subscribing to EP Edge Journal Watch for weekly high-yield research analysis and to the EP Edge newsletter, where we take deeper dives into topics like pulsed field ablation, covering mechanisms, outcomes, efficacy, and complications shaping the future of our field. Thank you for listening, and thank you for being part of the EP Edge community.